Hello, everyone, and welcome to today's webinar. My name is Charlotte Zwart, and I will be today's host. I'm a customer success manager at Encare. Encare is the organizer of this webinar and also the provider of the ERAS implementation program and the ERAS interactive audit system. It's my pleasure to be your host today, as together with two fantastic speakers, we'll explore how ERAS can be successfully implemented in hip and knee arthroplasty. We will start the webinar with a presentation followed by a Q&A. You are welcome to post your questions in the chat. If you prefer to ask your questions anonymously, you may also click on the link that my colleagues from Encare will provide. We'll try to address all the questions at the end of the presentation. Now I will introduce today's speakers. First, we have Dr. Thomas Boogmans, Head of Clinic at the AZ Rivierenland Orthopedic Center in Belgium. He has extensive experience leading ERAS in orthopedic surgery, and today he will guide us through the nuts and bolts of ERAS in hip and knee arthroplasty. We also have pharmacist and clinical biologist Laura Boogaert, also from AZ Rivierenland. She specializes in implementation strategy and care pathway redesign. Today, she will share practical insights and lessons learned from real-world experience. For practical reasons, our speakers are sharing one computer. Now I will leave the floor to our speakers.
Okay, thank you very much, Charlotte, for the very kind introduction. So let's start. We'll start sharing our screen and hopefully this works, all right? So please give us a sign if there should be any problem. A very warm welcome this evening in Belgium, and let's start. So we can skip immediately the disclosures, but we do want to know, of course, immediately who you are today. So let's try a short interaction. You can all take your smartphone and your camera, scan the QR code on the left upside of the screen. And so let us know, you know now who we are because of the introduction. And we want to know, of course, if we have tonight a multidisciplinary audience, of course, which we hope from an ERAS point of view. Good. Managerial board, allied health. Very good. So very heterogeneous here. So that's very good, because that's what we hope, of course, which is one of the cornerstones of enhanced recovery after surgery. It's all about multidisciplinary teamwork. And also even the dear colleague surgeons are present, which is a pleasure to see, of course. Okay, so let's go. So what is the goal of this evening or this lecture, of course, that you have a key understanding of ERAS principles in orthopedic surgery, that we provide you some practical examples of ERAS theory, and that my colleague, Laura, will explain a bit on how to implement ERAS, because we will explain tonight, which is one of the key principles to understand, is that knowing how to do something is not the same as knowing how to implement something, okay? And we will close, of course, with tips and tricks to guide a successful implementation. All right. So let's start with the first part, the nuts and bolts of ERAS in hip and knee arthroplasty. We flip the script, all right, because we assume that you want to know, of course, who is talking to you. So we are very transparent to show the results of our center, okay? We work with the IAS system. We will explain it, of course, during the presentation. But here you can see our results, okay? So in hip and knee arthroplasty, so we have in the lower part of the screen, you can see we have a mean length of stay of hip arthroplasties of 1.7 days. For knee arthroplasties on the right side, we have 1.8 days mean length of stay. A complication rate around 8% to 10% for total hip and total knee. Reoperations around 3% to 3%. Readmissions between 2 and 3.5%. If we look more into detail worldwide, but we always have to be careful, of course, with the studies that we look at, we see that, for example, worldwide complication rate 90 days for hip and knee is between the 3 and 8%, okay? We see readmission rates around 8 to 10% and reoperation rates around 1%. So does that mean that our hospital is doing good or bad? Well, it is at least a benchmark. It's an important benchmark. And of course, when we go into detail, you can see that, for example, in our hospital, What do we take as complication? And this is something you really need to understand if you read studies, is which type of complication did they include and which type of complication did they not include, because it can make your results completely different. And as you can see, we include, for example, pain or postoperative pain as a complication. And then, for example, you see why we come, for example, for hip and knee around 8 to 10%. Most common complications are periprosthetic fracture, a dislocation or wound infection, or for a knee arthroplasty, joint stiffness, which you probably all know can happen, and then, of course, a wound infection or urinary retention. So that's a very important part. This is the auditing and monitoring of your practice, also one of the key elements of enhanced recovery after surgery, which we will explain in a few moments. So when you think of ERAS, you will be able to scan again the QR code. What does it mean to you before we start explaining the core principle? What is ERAS to you? You will be able to type everything you want, but what pops up in your mind when you hear the word enhanced recovery after surgery? We're always very curious when we ask this question, because then we know immediately who is already educated and who's still actually, let's say, novice in the field. And that's good, because then there is something to learn, of course. So let's take a look. Best rehabilitation, faster, quicker recovery, less complications, culture, change. Okay, this is great to see. Okay, this is really great to see. Optimizing care, teamwork, perfect. Okay, we can still learn you something, I think, but the good thing is that we will be on the same line for a lot of things. So let's go. Let's talk about the theory. So in 1997, as most of you will probably know, a landmark paper was published by the Danish surgeon Henry Kellett. And little could he have known that it would become one of the most cited papers in the world that we call today of enhanced recovery after surgery. Okay. And his paper was all about the surgical stress response that happened in patients undergoing surgery and how we could mitigate this response. This concept became known as enhanced recovery after surgery, a multimodal, multidisciplinary approach to reduce this stress response, reduce organ dysfunction, and enhance recovery. As you all know, the ERAS Society was founded then in 2009, and multiple guidelines were developed. For the scope of today, we will focus, of course, on the ERAS guidelines published by Thomas Wainwright in 2020, but we do want to inform you that those are, for example, not the only guidelines on hip and knee arthroplasty, although they have 17 recommendations, of course, for ERAS, for hip and knee arthroplasty. But there are, for example, also the American guidelines coming from Ellen Sofin. And then there is even the criticism on those guidelines that they do not have, for example, all procedure-specific evidence that, for example, hip and knee arthroplasty, that there is slightly more advantage by doing neuraxial versus general anesthesia, that they lack, for example, the use of preoperative high-dose corticoids, and that maybe some elements are more important than others. And this is the first interesting part, because you see that there are multiple guidelines, but you will see the most important one are of course, the one of Thomas Wainwright. And then you have the American guidelines and the criticism. Now, what do you think that happens? Well, what happens in real life is that you get, of course, in all over the world, the publication of studies where everyone does some things of the ERAS protocol and some things they don't do. Just to give you an example, most studies include, for example, preoperative education. Most studies include early mobilization, but then it becomes more difficult. And then you see the publication of different protocols for enhanced recovery after surgery in hip and knee arthroplasty. But the strange thing is that they all report similar outcome improvements. So all those reports, although there is variation in the type of ERAS, they do report the same type of outcome improvements, like, as you all probably know, a reduction in length of stay if you think that that's the most important, of course, reduction in complication, reduced readmissions, improvement in function, reduced transfusion, and so on and so on. This is, of course, the cornerstone of ERAS. This is why ERAS is so important to implement, of course, in your hospital, because of all those advantages associated with implementing enhanced recovery surgery in hip and knee arthroplasty. So we have different protocols, but similar outcome improvements. But what does that mean, of course, for your practice in your hospital? And this slide is therefore one of the key slides of our presentation today. What do you need to know today in 2025? Well, first of all, from all those elements, there is no consensus which care elements or the combination thereof are the most important. You do need to understand that one size does not fit all. I will explain, of course, why. We will show, for example, our interpretation of the ERAS guideline, but you will see that variation in this protocol can be allowed and will lead to the same outcome improvement. Okay. Number two, the benefit of ERAS comes from standardization of care in your local context. That means in your hospital. Okay. And that the variation within a set of core elements is less important than providing the core elements themselves. I give you one example. Whether you give tranexamic acid as a part of your protocol, if you give it IV or peroral or topical, it probably doesn't matter as long as you include tranexamic acid, for example, in your protocol. Okay. But what do we know is that probably that set of core elements must include at least those three things. And that's the use of multimodal opioid-sparing analgesia, the timely use of, in this case, antifibrinolytic administration like tranexamic acid, and of course, early mobilization. And those are three elements that we see consistently returning into different studies. Okay. What do we also know is that if you create your own protocol in your hospital, your local protocol, that the higher you adhere to that protocol, the higher compliance leads to improved outcomes. And one of the most famous studies about this was, of course, the Power 2 study by Ripoles, Melchor. And they nicely showed, as you can see on the graph on the right side, that quartile 4 was, for example, the group of patients that adhered the most to all the different elements, and the outcome over there seems to be better than those adhering very low to the guidelines. And last but not least, don't think of ERAS just as a protocol. Probably implementing the whole concept, providing the pathway en bloc, as we say, is better than the sum of the parts. This slide is key. This slide should be one of the cornerstones to take with you home tonight. So let's go to practice, of course. Starting from the theory from the ERAS guidelines, we created, of course, our own interpretation of the protocol, but including all the different 17 care elements. We will walk you through it. Blue part is the preoperative part, green part is the intraoperative part, and red is, of course, the postoperative part. What is the most important thing to understand from this slide? Well, as you can see, this is all about multidisciplinary teamwork. Okay, you can't do this alone. You will need to sit around a table with everyone, and it will start with the first email towards all different stakeholders to come around the table, and talk about the implementation of this protocol. Okay, so preoperative, we promised to give you practical examples, and that's what we're going to do tonight. You see an example of the preoperative education of patients. How can you do it? Face-to-face, leaflets, joint classes, buddy programs, inviting, for example, the partner of the patients, a friend of the patients, virtual telephone calls, apps, or like in our center, for example, an ERAS nurse available. Joint classes, very interesting, of course, to educate patients. Why should we do it? Because there is low to moderate evidence that it reduces anxiety in patients. It has several advantages in terms of pain management and functional improvement. in some studies, it's also associated with decreased length of stay. So we would recommend to perform it. That's also the reason why we do it in our hospital. A second important part in the preoperative ERAS pathway for hip and knee arthroplasty is, of course, get your patient at his best before you start the surgery. And that means, for example, optimization of chronic diseases. This slide or this picture should probably change your life or your view about diabetes patient or glucose problems. Here you can see that, for example, in patients, even without diabetes, the elevated blood glucose before surgery and after surgery is associated with increased odds of mortality. Now, what does this mean? This means that you will have to screen your patients based on a risk score. We advise, for example, the FINCH risk score, and determine the hemoglobin A1C, for example, to see if your patient has diabetes or poorly controlled diabetes, okay? Because you will see if you do not screen for it and it's too high, it is associated with adverse outcomes such as mortality and increased wound infections. So optimization of chronic disease is a very important point, which can start, for example, with the first consultation at the ERAS nurse or the preoperative consultation. Second important point is prehabilitation. We do not know if you already heard about prehabilitation, but to summarize current evidence, I can tell you already that prehabilitation is associated in hip and knee arthroplasty with improvements in muscle strength and health-related quality of life. Okay, not only before surgery, but only up to 12 months postoperatively. Now, the question is, what is prehabilitation? Well, prehabilitation is actually, for example, it consists out of 5 parts nowadays, okay? And the first part is preoperative exercise. Yeah? That means that your patient should not only mobilize after the operation, but should be exercised before the operation. The goal is to get your patient more fit, if possible, by doing aerobic or anaerobic exercise and to train him to get him faster, self-independent after the operation. So preoperative exercise. Second important part is, of course, nutrition. Okay. Nowadays, there are a lot of studies coming out about the importance of nutritional screening, which can be both under and overweight in hip and knee arthroplasty, although we see more overweight. Okay. An interesting score can be, for example, the MUST score, M-U-S-T score. Second, short fasting policy in your hospital, which we also do, of course, 6 hours for light meal and up to 2-hour drinking of clear liquids. Please advise your patient to do it. We do know that it sometimes can cause problems in the operation planning, but do know also that you want your patient to get in an anabolic state just before the operation and not a catabolic state. Okay, and this is important. That's the reason why you will find in the guidelines, for example, carbohydrate loading, low to moderate evidence for it. But please do know that carbohydrate loading does not mean drinking a sports drink 2 hours before the operation, because the sugar in it is not enough. You will need more. So if you want to do a real carbohydrate loaded, and there is more evidence, of course, to do it in colorectal surgery, but if you want to do a carbohydrate load, you will need to give enough, as you can see, okay? 50 grams in 400 milliliters diluted the evening before and 2 to 4 hours before surgery. Why? Because it reduces the postoperative insulin resistance, it improves your patient satisfaction, of course, and also the muscle function, okay? So if you do it, we do it, then it's very important, of course, to give enough. We avoid it in type 1 diabetes. Why? Because it can cause problems in sugar or glucose level. But in type 2 diabetes, for example, it's quite safe to give. Last important part, because smoking cessation, alcohol cessation is quite obvious, I think, in hip and knee arthroplasty. It is extrapolated evidence, but I do assume that you know that at least quitting 4 to 8 weeks before the operation is important in terms of pulmonary function. The most forgotten element in ERAS pathways is what we call patient blood management. Okay, patient blood management is a very important part and means or one of the things that it means is, of course, screen your patient for preoperative anemia. Preoperative anemia, allogenic transfusion, and blood loss are 3 dose-dependent and independent risk factors for adverse outcomes. And therefore, we mean renal problems, cardiac problems, increased length of stay, and so on. Okay, that means that preoperative anemia screening is crucial, and treating preoperative anemia is even more important. Okay, when you look back at this presentation, we will share it, of course. Please take the time to look at articles about patient blood management programs in orthopedic surgery, because it is key to understand this. Up to 25% of patients is anemic before the surgery. Okay. So we have, for example, and this is in Dutch, we excuse us for this, but we just want to highlight here that you can build a flowchart where you screen for iron deficiency, for example, vitamin B12 deficiency, folic acid deficiency, and you can treat your patients with oral iron, IV iron, EPO, for example. Okay, those are things that should be done to improve the outcomes of your patient, and is essential also in the preoperative pathway for ERAS in hip and knee arthroplasty. In the intraoperative part, one of the most important things is, of course, minimal invasive surgery. Now, what does that actually mean? Of course, we advise minimal invasive surgery because it causes less tissue trauma. But that's not so easy in hip and knee arthroplasty. It does exist for total hip arthroplasty, minimal invasive approaches. But it's not so easy for a total knee where the incision length is most of the time quite long. But we do advise not to use any tourniquet, which is also in the guidelines. Yeah. Please do know that the tourniquet does not reduce the total amount of blood loss, and it causes problems with muscle damage. Okay, tourniquet use can decrease the intraoperative blood loss, but not the total blood loss on itself. Okay. Second part, do you have to do general or spinal anesthesia? Okay, there is no recommendation in the guidelines whether or not you should use general or spinal. There was a lot of criticism on that based on a study published by the group of Stavros Memtsoudis, the ICARUS study work group. And because they recommended, due to literature search, that Neuraxial was probably in favor, well, you do need to know, for the anesthetist among us, that you have to know with what you compare. Okay, there is a big difference also between inhalation anesthesia and total intravenous anesthesia. Just to give you an example, we use most of the time total intravenous anesthesia with propofol and remifentanil. And for example, one study coming from the Scandinavian countries nicely showed that this was not inferior and even better than, for example, spinal anesthesia. But please do not understand me wrong. We are, of course, for our total knee arthroplasty, we do use Neuraxial anesthesia, which has very good advantages, but both techniques have their advantages and disadvantages, and it's not that one is actually to be considered superior than another, depending on what your goal is for your patient. Okay, but it is true that in most recent literature there is more overweight, showing that Neuraxial anesthesia is associated with decreased risk of DVT, pulmonary embolism, for example, and blood loss. Okay, but now we come to one of those 3 previously mentioned cornerstones, the core elements: multimodal, opioid-sparing analgesia. So what does that actually mean for your hospital? It does not mean that you have to use all of these mechanisms, all right? Like I said before, okay, the variation within the set of core elements is probably less important than providing the core element on itself, okay? At least it should be logic to use 2 or more different analgesic products to get your patient pain-free, okay? Paracetamol, non-steroidal agents are the minimum. And then, of course, you have the choice, okay? Just to give you an example, as an anesthetist, we are in favor to use local regional anesthesia, for example. But the surgeon can also do a local infiltration of the knee. Is one better than the other? Probably not. Probably that doesn't matter. But it does matter to provide at least analgesia. Let's talk about the knee, for example, by an anesthetist performing an adductor canal block and an IPAC block, or a surgeon that performs a local infiltration analgesia. Okay, so one of the two. You can also use, for example, ketamine, also known as special K sometimes, for those that go out, magnesium, and then, of course, the high-dose corticoids, which we will discuss in a few moments. But please, multimodal opioid-sparing analgesia is key. The goal is to reduce the opioid consumption because of the deleterious effects such as itching and constipation and so on. Perioperative fluid therapy, also one of the ERAS elements. What should be the goal? To, of course, have a maintenance fluid to replace the losses, but please do remove the fluid upon discharge of the post-anesthesia care unit. Fluid is like a drug. You have to prescribe it. There is too many variation in giving fluids in hip and knee arthroplasty. It can change between 1 and 6 liters. So we need to standardize it. So here, just to give you one example. Then, of course, one of the criticisms on the guidelines was the use of high-dose corticoids. Okay, just to give you a summary, do you need to give preoperative high-dose corticoids? Well, intraoperative high-dose corticoids. The answer is actually yes, you need to give it. Okay, why? Because it decreases the pain. Okay, it decreases opioid consumption, nausea and vomiting, and there is no evidence that it increases joint infection. Okay, does the dose matter? Probably. Probably high dose is better than low dose. Do you need to give additional doses? Probably yes, up to day 2. Are there contraindications? Sometimes I hear surgeons who are afraid of avascular necrosis not coming from 1 or 2 doses. But you need to monitor your glycemia. What do we give in our center, for example? Well, on day 0, we give dexamethasone 20 milligrams or methylprednisolone 125 milligrams, but we do exclude type 1 diabetes because of the problems of glucose levels postoperatively. You have to monitor your glucose. On day 1, we repeat the dose, of course, and for our outpatients, because we also do hip and knee arthroplasty in an outpatient setting, which we call same calendar day discharge, we also give oral cortisone at home, 2 days. Then, of course, antibiotic prophylaxis, which is quite obvious. And then, of course, tranexamic acid. What do you need to know about tranexamic acid? Well, in our center, we chose to give it intravenously at a dose of 20 milligrams per kilograms. Please do know that there is still a lot of discussion in the literature. In the last 2 years, there are more studies coming out to give the combination of topical and intravenously, but still there is a lack of high quality studies showing that, for example, one is better than the other. So up to now, you can even give it orally, but the most important part is, like I said already in the beginning, the essential is to provide the core element, and the way how you provide it, for example, in tranexamic acid, probably at this time is not yet clear, but you need to give it. Normothermia is quite clear, of course, because a hypothermic patient bleeds more, and then, of course, you have to give adequate PNV prophylaxis. Last part is, of course, the postoperative part, okay? What is key for you to know in your hospital, in your local ERAS protocol? Please do include early mobilization. It has nicely been shown that mobilization on the day of surgery increases your odds of the patient to discharge, okay? In most articles, you will find that mobilization should occur at least within 24 hours. We would like to stretch, in this case, that the sooner the better, okay? But this will demand a cooperation between your anesthetist, physiotherapist, of course, and your patient. If your anesthetist does not provide a good anesthesia and the patient has nausea or orthostatic intolerance, the physiotherapist will have problems in walking with the patient. So that's, again, the importance of sitting around the table with the whole team, okay? Early mobilization reduces the risk of postoperative complications, accelerates recovery, and reduces hospital length of stay. So please try to work at least within 24 hours to mobilization, and if you can, mobilization on the day of surgery. Standard discharge criteria. We provide you here with the example how we do it in our hospital, okay? But it is very important to have that, because otherwise you will render your patient to the discretion of the surgeon about his or her discharge, okay? In our hospital, for example, we have our nurses that check the discharge criteria every day. And if they are fulfilled and if they are okay, they call the surgeon and they say the patient is ready to go. And that's how you create a minor gap between ready for discharge and final discharge. Okay, so those criteria are quite important. Last part, of course, and always a very interesting part, is do we need to give antithrombotic prophylaxis or not? Well, the answer is quite simple. There are many guidelines, but there's a little consensus about it. Okay, you will see, for example, in European guidelines that they will stratify the risk depending on the majority of procedures, whether or not hip or knee is a high-risk procedure, and the patient has a high or low thrombotic risk. But you will see, for example, that in the American guidelines, for all hip and knee arthroplasty, low-dose aspirin is currently the most recommended method. In our hospital, we do give patients low-dose aspirin, but we make a stratification. If they have a high-risk profile, according to, for example, the Caprini score, then we do give low molecular weight heparins. You will see in studies in the Scandinavian countries that they reduce the antithrombotic prophylaxis only to, for example, in-hospital prophylaxis, but you do understand probably that the sooner you mobilize your patient, probably the less need you have for antithrombotic medication. Okay, so with this, we would like to conclude this first part about the nuts and bolts of ERAS in hip and knee arthroplasty. Now, let me give you the word to my dear colleague, Laura, who is implementation expert of ERAS in our hospital, and will explain you the tips and tricks about implementing ERAS in your hospital.
Okay, good evening. So now we start with the second part of the presentation, how to do practical implementation of ERAS. And let's start with a question for you all. What do you think that the current mean estimated ERAS adoption rate is worldwide? Do you think that it's more than 80% or between 16 and 80%, between 40 and 60%, less than 40%, or is it highly variable? So I think everyone has answered, but yeah, the right question was that it's highly variable. Why is it now so highly variable? That's there are a lot of key factors that makes the ERAS adoption rate so variable. First of all, we see a very big difference between different surgical pathways. There are surgical pathways where the ERAS adoption rate worldwide is higher than in other surgical pathways. Then we see also a very big difference in different countries and different regions. There are countries with a very, very high ERAS adoption rate, but there are also countries with no adoption rate. Then we see a big difference when it's fully or partially involved in your hospital, the ERAS protocol. And then there are also other local hospital factors that make the ERAS adoption rate very variable. As we've seen in the first part of the presentation, an ERAS pathway is from pre-admission until post-discharge. So there are a lot of people involved in the pathway, and it's important that all the people change their way of working to the new pathway of ERAS. And now we can go to the change, because change, you have to do a change in your work, and change is an emotional journey. People typically move through several stages before they embrace this change. most of the time it starts with shock and denial. One of the sentences you heard then is, "This can't be real, don't do it." There come a resistance phase with frustration, anger, and blame. But when they start testing the new way of working, and when the curiosity takes over, then you come in a sort of exploration phase, acceptance phase, and afterwards there is a commitment, and they embrace the change fully. So this is this change pathway everyone will go to when they have to change their work. So this is the individual change pathway. But when we look at the population, we see that not everyone adopts the change at the same speed. So there are people that change faster than other ones, and we can group all people into 5 categories. First of all, we have the innovators and the early adopters, and that are the people you need in the first phase of an ERAS implementation, because that are the first movers, the role models, risk takers, etc. Then you have the early majority, and the early majority will join when they have a little bit of evidence for the change. After that, you have a more difficult category that are the late majority, because they are very skeptical and they need strong proof to do the change. So in the first phase, they will not go into your project, but afterwards, when they see data, they will follow your project. And the most difficult category are the laggers. They are very, very resistant. A tip for you, don't lose your energy for the laggards, but search for the innovators and the early adopters to follow your change project. So this is how a fully population, also in your hospital, will react on the change. We all know that ERAS is a quality improvement intervention, and that needs 2 things. First of all, it needs a quality improvement method for structure. Some of methods are the PDCA cyclus, lean management, or Six Sigma. And then you need also a change management framework that's more for the people to follow your change. And there, a popular method is the Kotter model, or the knowledge to action cycle. But when we look at all the methods and frameworks, there are 4 key elements that all the methods and frameworks have in their framework. First of all, you have to assess the current state before implementation, and it's very important that you do it before implementation. So after, first of all, you can show why you have to change your work. You can show the gaps, like we will see in the next slides. But also, when you have implemented your change project, you can also prove your what goes better, etc. Secondly, every quality initiative has to be evidence-based. Then develop also a change management initiative to support your implementation. And very, very important, measure your performance in every step of your change project and give feedback to all stakeholders. So implementing ERAS is all about changing the mindset, and now we will go more in detail in the Kotter's 8-step change model. The Kotter model has 3 phases. So first of all, create climate for change, enable and engage the organization, and implement and sustain. And it has 8 steps where we go more in detail now. So first of all, create climate for change. Very important step is to create the urgency in your organization. So when you help others to see the need for the change, they will be convinced of the importance and acting more faster than others. Do the first assessment of the initial situation and show the data to everyone and identify the gaps and show also the gaps to everyone. So then they will know why they have to follow your change project. Secondly, a very important thing in an ERAS project is to build a strong coalition. A strong coalition in ERAS is, of course, multidisciplinary because it spans from pre-admission until post-discharge. So there are a lot of people involved in the project. It has to be motivated people, and like we've seen before, the early adopters are the best people to have in the first phase of your project. You need also a strong, motivated clinical champion or a leader. And very important is to have frequently ERAS team meetings. We've did in the implementation phase every 2 weeks a meeting, and now we are in the maintenance phase for orthopedic surgery, and now we do every 2 months meeting. So then another step is to create a vision. A vision has to be clear, easy to understand, easy to communicate, and easy to remember. But very important is that it has to be positive. And more important is that it has to encompass all members, but also the patient, because ERAS is all about the patient. So also the vision has to encompass the patient, and it's also to be communicated, but that's the next step. So the next step is to engage and enable the organization. And first of all, you have to communicate the vision and use every channel you can use. So mail, intranet, posters, quality meetings, an e-learning. We've did also in our hospital a kickoff meeting for the whole hospital. Do regular presentations, and of course also continuous staff education, because that's very important. So then a very important step is to empower others, but more important is to identify and quickly remove or bypass obstacles. And there are 2 obstacles. First of all, you have the human obstacles, and then you have the other obstacles. But we will start with human obstacles. And this is a little bit a lesson on people management more than on change management. But you have different characteristics in your organization, and you have some hypos in your organization that are the highest paid person's opinions. Most of the time that are the directors, the CEOs. They have they are important to have on your project and to stay on your side, because they will be your biggest supporters when they see good results for you. Then you have the rhinos, the really here in name only, that are mostly the seniors, the senior clinicians, but also they are very important because they can be your advisor for going to the directory board or something like that. Then you have the zebras that are the zero evidence but really arrogant people. But you have to know that they are not against ERAS, and they are good in what they do. So you need them also. But they don't follow your project in the first time. The people you have to include in your project are the eagles, the eager to learn enthusiastically people that's the future. They will get things done, and that mostly are the young trainees, nurses, residents, etc. Then there are a lot of other obstacles that you can have in your project, like resistance from healthcare professionals. And over here, there are a little bit of phrases that you can hear in your hospital. I want to implement ERAS, it's important. And someone else say to you, no, we are already doing ERAS. So that's something you have to identify quickly, but also bypass or remove it, like in this case, show them data, show them the gaps of the current state, and show them why they have to do the ERAS and what's now the status is. Then you have also resistance from patients, you have also limited resources, etc. So another important thing is to create quick wins. We say also that it's low-hanging fruit. So like there are recommendations for orthopedic surgery, and you have to pick the things that are easy in the first time, that are easy to implement, that are inexpensive, easy to understand for everyone, but very important, also visible, that the result is also visible for everyone, and that your compliance is higher, and of course your outcomes will be better. But that are things that you can implement very soon in your project. Then the last phase is to implement and sustain. So build on the change. It's very important to have a real-time system for compliance and outcome data. Like I said before, you have to, first of all, have the current state before implementation. So you need a zero database. And then after the implementation, you have to continuously focus on the different ERAS parameters and set further goals. You have to monitor your key elements, and you have to see why you see like a drop or something like that. Is it because there is other staff in your hospital, or something like that? So of course, you have to expand ERAS across other surgical disciplines. Now we are implementing for colorectal surgery and urological surgery in our hospital. And also you have to motivate your hospital staff to attend lectures and study publications. And then the last step is to embed the change in your hospital. ERAS should be the standard of care. ERAS should be the culture in your hospital, and not a project anymore, but just a normal way of working. It has to be an intrinsic part of your staff training and education program. And of course, you have to routine report your key parameters and say it to everyone in your hospital what you are doing. So now I give the word to Thomas to say what we've done in our hospital.
So we're almost at the end of the presentation, but maybe this can help you a little bit if you are struggling, or maybe not, in implementing ERAS. We started in 2018 with a kickoff email and the first multidisciplinary team meeting. At that time, the meeting with the managerial board was quite short. It was a good initiative, but there was no funding. So between 2018 and 2021, we organized with different staff members, different meetings, and we started the ERAS way of working. We had no ERAS nurse, but in the beginning, results were monitored just by a local Excel file. And then afterwards, we used GRAS database, which is also a database that is online available, because we did not have any more funding. It was only afterwards, of course, that in 2021, we had some media attention in Belgium when we had a publication around outpatient hip and outpatient hip arthroplasty. At that time, of course, the managerial board became interested, and they said, okay, this is a very interesting project. So what did you do achieve outpatient surgery with your ERAS program? Although this is not the primary goal, of course. And then, of course, the funding started because of the hospital got some attention from the media. And so first using GRAS as an audit system or Excel file, maybe this can help you, of course, in the beginning if financial funding is a problem in the beginning. But then, of course, afterwards, we started following an extra ERAS implementation program. And nowadays, of course, we use the ERAS interactive audit system as a database. The crucial step is, of course, like I said before, it's one of the important elements. The most important part is that you use a database, okay? And if, for example, in the beginning, there is not the funding for, in this case, the IAS system, then there are still other possibilities and things can grow, okay? In September 2023, we became an ERAS qualified center. And then in 2023, we also started with outpatient total knee arthroplasty. So the take-home messages, of course, implementing ERAS is a lesson in change management. Okay, many clinicians, many nurses do not have an education. They didn't have. I didn't have it when I studied medicine and anesthesiologist. But it's key. okay? Because knowing how to do it is not the same as knowing how to implement it. And the practical implementation of ERAS requires leadership, requires teamwork, a good vision, a strong vision, and needs a good communication with short-term wins that keeps everyone motivated, but most of all, of course, a good database where you monitor your praxis. So let us end with the 10 commandments for ERAS implementation in your center. One of the key slides, I think, also for tonight, is, first of all, ERAS is more than a protocol, okay? ERAS creates an ERAS culture in your local context. The sum, of course, is better. The whole protocol is better than the sum of parts. 2, enhanced recovery after surgery applies to any patient, okay? And the frailest benefit most. Outpatient surgery is not for every patient, but ERAS is for every patient. 3, don't focus on the fast, please, because focus first on getting your patient better, and you will see the results, and faster will come. 4, like I said already, knowing how to do it is not the same as knowing how to implement it. Get that person on board who has experience in change management, knowing that ERAS is a quality improvement program and needs a quality improvement method to implement. 5, in the world of today, it's not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. ERAS is all about change management. It's not easy. But if you help to see others the need for change by showing the data, showing the gap, showing the evidence, they will be convinced of change. Think about it when you organize, for example, that kickoff meeting for your hospital, and educate, educate, and educate. 7, how do you receive the best results? Well, it's not you. It's your team that achieve the best results. There is no I in team. And this is a crucial step, especially for the clinicians among us. 8, crucial. You can't manage what you don't measure. Monitor your pathway, audit, and compliance tracking is crucial. How you do it, there are many ways. We gave some examples: Excel, the GRAS database, or IA system. And it depends, of course, on your local funding. But please think about the ERAS element on itself. 9, the price of victory is high, but so are the rewards. Please do know that implementing ERAS leads to reduced length of stay, reduction of complication, increased patient satisfaction, and many other things, also cost savings. ERAS is a crucial example of value-based healthcare, another important concept developed by Michael Porter. Okay, so ERAS can be considered value-based surgery. Okay, and 10, think about it also. Rome was not built on one single day. Change takes time. With that, we would like to conclude our presentation. Thank you very much for your attention. And if there should be any questions, we will be happy to answer it, or today or afterwards. We will always be able to be reached via email. Thank you very much.
Thank you so much both for those valuable and very practical insights. I'm sure the audience appreciates it very much. We actually got quite a few questions during your presentation, so we will, I think we'll aim to address all of them during this webinar. The first question: in your multidisciplinary team, do you include a geriatric doctor? And maybe connected to that, for elderly patients, is it better to have them in the post-op under the care of standard surgery ward or under the geriatric ward?
It's a very interesting question. The geriatric, the geriatrician was already included because there is a connection, there is a pathway in our hospital, which is a connection between the orthopedic surgeon and the geriatric physician. But the geriatric physician is not present on the ERAS meetings. It only gets consulted when necessary. So the geriatric doctor is not present on the meetings, but is involved through a specific geriatric orthopedic pathway in the hospital, indirectly.
Thank you. Then another question about the beginning of your presentation. How long do you treat anemia with oral iron before surgery?
Maybe Laura
Yes.
want to answer it?
Yes, we treat patients minimum 6 to 8 weeks before surgery, but more early is of course better for oral iron therapy.
We do have to admit that although it takes time with oral iron therapy, 6 to 8 weeks is the minimum you need to increase the hemoglobin at least 1 or 2 points. You can achieve faster results, of course, by giving IV iron, which can be prescribed, for example, in Belgium, in our country, by the anesthesiologist, and we commit to that in our hospital. And please do know that if you do that, you can achieve good results within 2 weeks. So if you have reimbursement for that, then of course we would suggest to give it at least 2 weeks before the operation to at least have a 75 to 80% response, which means more or less 2 points increase in hemoglobin.
We have a few more questions on that topic. If hemoglobin okay and ferritin normal, all good. Why does my hospital want a super normal ferritin?
But let me check the question.
From David Mitchell.
That's
Maybe because the iron saturation is low, I think. In that.
We would have to look it into detail, but if you look into patient blood management guidelines around screening and treatment of preoperative anemia, so what do you need to know? Is that first of all, preoperative anemia is associated with worse outcome, but what also has worse outcomes is a preoperative non-anemia, but iron deficiency. Okay, so that's something you also need to treat. But when the hemoglobin is okay and the iron, the ferritin is normal, then there probably should be no reason to give iron unless the transferrin saturation is very low and your patient has an inflammatory status. Because in an inflammatory status, ferritin automatically rises and your levels change, and then you have to look at the transferrin saturation. So to our dear colleague Mitchell, we would like to answer that maybe one of the things that the hospital monitors is also the transferrin saturation, and if that's, for example, below 20%, then there could be a reason to think of, for example, an inflammatory disease or comorbidity, which still makes it possible to give iron. So you need to look at the hemoglobin, the ferritin, and the transferrin saturation. So those 3 things are quite crucial to look at.
Thank you. Elizabeth is asking, we have an excellent PBM program at our hospital. However, I don't think our surgeon utilize it to its full advantage. Do you have any suggestions to increase usage of PBM?
But the interesting is that we also have implemented a patient blood management program. Like we said in the implementation part, is that in the beginning, our surgeons were not able to use to do the screening of preoperative anemia and treatment. Why? Because sometimes their surgery got delayed for that. Okay, but then when showing the data about the reduction in transfusion, the good results on the so reduction in transfusion, increased hemoglobin, and so on, they got convinced that it was actually better. And nowadays they are not against delaying surgery to optimize patients. And so what did change was the education. Was the fact that, for example, we were able to take our surgeons to ERAS meetings, the ERAS Congress, for example, and that they got curious about it, and that their practice changed. So showing them, and probably your hospital has data on transfusion rate, transfusion index, preoperative and postoperative anemia. And if you can show them the difference by just implementing a single unit policy in your hospital as part of a PBM program, or a pilot project with oral IV iron, we are quite sure that they can be convinced of that. But you will need to educate them. And if one of the surgeons get convinced and the others see the difference, well, then you get the early majority, as we call them, that will change also. But you need to find that one surgeon, often a young surgeon, that is interested in it, and where you can tell your story and who wants to start with you a pilot project about it. And if that's successful, you will see that the other will come one by one.
In our hospital, the ERAS nurse helps a lot in that case for the preoperative consultation. She managed the iron status, etc., together with the anesthesiologist and the clinical biologist by me. So I think that's a good point to manage the patient better for the anemic part, I think, before surgery.
Yeah, and speaking of the ERAS nurse, the next question, is your ERAS nurse in the clinic or hospital?
We do
in the clinic or hospital?
We do not.
What's the difference?
Patient difference.
But I think we
We
do
work
not.
in a hospital, so we work in a hospital. So I think that's the answer also.
Yeah, because the question is not quite clear, I think, because our ERAS nurse works in the hospital, and her job, if I can say it like this, is actually she's involved in the whole trajectory of the patient. So she does the preoperative consultation, she visits the patients on the day of surgery on the ward, she calls them after the operations to check for the patient-reported outcome measurements, the PROMs and the PREMs. So she's full-time actually present in the hospital, and she partially works as a hemovigilance nurse, which is interesting for our PBM program, and she partially works as an ERAS nurse. I hope this answers the question, because it's not 100% clear to us.
Thank you. Next question. When you speak of complications, do you mean complications that occur while in hospital, or complications that occur after discharge and they need to return to the hospital?
That's a very good question. Both. That depends on the database that you use. Like we said, we used different databases. We started with just a simple Excel file. We went to a GRAS database, and then we went to the IAS system, and the IAS system monitors your complications in hospital and up to 90 days after surgery. So it's a combination of in-hospital complications and complications up to 90 days post-discharge.
Thank you. And then one more question. How are you able to remove barriers to pre-op optimization?
Okay.
We have a sort of pre-op. It's not a pre-op clinic, but the ERAS nurse do every element of the preoperative optimization program. So, and also, like you said before, we have also the PBM implementation program. So both are coming together a little bit at that point.
We think that it's crucial to have that pre-op optimization. So if it wasn't clear, maybe it's not a bad thing to elaborate on that. The ERAS nurse in our hospital, I think I want to stretch that. I think an ERAS nurse is crucial. Okay, we are very grateful about our ERAS nurse. She does a very good job. She sees the patients preoperatively. She plans the blood samples. She plans the joint class, and patients are, for example, ready with their blood sample and, for example, EKG when they come to the joint class. At that joint class, I'm often there. I check the lab. I check the EKG. If there are any problems with preoperative anemia, then automatically the clinical biologist, Laura, is involved, and she asks the extra tests, like the iron tests and so on. At that time, The joint class is always planned at least, we try to plan it at least 2 to 3 weeks before the operation. Yeah. That means that we still have time to do the preoperative optimization. Okay. So this is quite important. In the beginning, we would say that the ERAS nurse and the joint class are two interesting things in the pre-optimization that can help you a lot. In the beginning, we didn't have an ERAS nurse, and it was mainly the anesthetist that took most of the effort to organize this. What was difficult as a barrier is that in the beginning, nobody wanted to make time for a preoperative education, that it was difficult. However, we asked to start a pilot project and divided the time between different surgeons, different anesthetists, and we had a good cooperation with the nurses, physiotherapists, and so on. And that means that in our joint class, we have the surgeon, the anesthetist, the physiotherapist, the ERAS nurse, the head nurse of the ward, and the occupational therapist that all come to speak to the patients with the goal of reducing anxiety. So if that should be a problem, if that could be a problem in your hospital, what is your alternative? Is that what we also did, is that you have a backup plan by creating digital videos where you can just easy let people talk for 20 or 30 minutes about their part of the pathway, which you can show to the patient. You all have a room available in the hospital, which you can probably use or to invite patients and their partner, buddy, to come, okay? And then dividing the work by multiple stakeholders can probably help. If it's not possible, then please do know that you can start with a brochure. You can start with, if you have a pre-op nurse, starting to explain it by the pre-op nurse. And then, of course, the most taking effort is, of course, by a joint class where all stakeholders are present. But this is something you will need to discuss in your ERAS multidisciplinary meeting, for which we have every 2 to 3 weeks in the beginning. Okay, and that's something you will need to discuss. But you will need to show the ERAS elements that are important in the preoperative optimization, such as preoperative exercise, smoking cessation, preoperative anemia screening, and the advantages. Somebody has to take the lead. You need that champion, that local champion. It can be an anesthetist, it can be a nurse, it can be a surgeon, but you need to have that person who's able to speak for the whole group and explain those things and why you want to do it. Okay. I hope this can help.
Thank you. We're going to take one final question for today. For how long should the implementation of an ERAS pathway be monitored after its introduction?
Forever.
Yes, forever.
That's an easy one. Forever. Yeah. And the reason is very simple, because we do understand that it can become difficult after some time to monitor the pathway. Sometimes you get tired of monitoring practice, but think of this. In your hospital, people change, stakeholders change, new nurses come on the board, new anesthetists, new surgeons. That means that something can change in the practice and that they are not all aware about the ERAS pathway. You will see that if you monitor your compliance. You will see a drop in compliance, and then that's the moment you will start to ask, how is it? Why is this happening? What happens? Why is the compliance dropping? Can be anything, but some of the things can be, for example, new staff members. Can be one example of it. You will not see it if you do not monitor.
And also your outcomes are very important to monitor.
Of course. Sometimes your length of stay suddenly increases, your complications increases. And the question is why? It can be that your surgeon is using a new technique, maybe a new cooling machine, something happens, new complications arise. So monitoring is crucial and should be forever.
Thank you. I saw a few questions about ERAS qualification, and that's something that we can address separately after this webinar. So that brings us to the end of today's session. On behalf of NCARE, I would like to thank Thomas Boogmans and Laura Bogaert for their expertise and time. And also thank you to everyone who joined us today and watched this webinar. If you would like to know more about how NCARE can support you in the implementation of ERAS or the audit, we'd be happy to connect with you later on. For now, we hope to see you at one of our next events, and thank you so much for attending.
It's a pleasure.